Welcome everyone to today's webinar. I am Becky Verzak with Becker Spine Review. We will begin today's webinar with a presentation, and we will have time at the end of the hour for a question and answer session. You can submit any questions you have throughout the webinar by typing them into your control panel in the space labels, enter a question for staff, and clicking send. We're looking forward to hearing your questions. Additionally, in about a week following the webinar, we will be sending you a copy of the presentation to the email you used to register. At this time, it is now my pleasure to start today's webinar by introducing our presenters. Dr. Priebus is a board-certified orthopedic surgeon who operates at the Carrollton Orthopedic Clinic in Carrollton, Georgia. Dr. Priebus graduated from Georgia Tech with a degree in mechanical engineering. He earned a medical doctorate at the Medical College of Georgia and went on to complete a residency in orthopedic surgery at the University of South Carolina, followed by a one-year fellowship in spine surgery at the renowned Scoliosis and Spine Center in Baltimore, Maryland. Dr. Priebus specializes in treating patients with problems involving the spine, such as neck and back pain, scoliosis, herniated discs, degeneration, injuries, and tumors. Dr. Bassett is a board-certified orthopedic surgeon who operates at the Southeastern Spine Specialist Clinic in Tuscaloosa, Alabama. Dr. Bassett earned his medical doctorate at the University of Florida and went on to complete a residency in orthopedic surgery at the University of South Carolina, followed by a one-year fellowship in adult and pediatric spinal disorders and reconstruction at the University of Madison, Wisconsin. Dr. Bassett specializes in treating patients with problems involving the spine, including acute cervical and lumbar disc herniations, instabilities, degeneration, stenosis, deformities, fractures, tumors, and revisions. Michael Veldman is the Global Strategic Marketing Manager for Envivio, where he has worked since 2011. He has over 17 years of experience in the medical device industry, including 9 years in product development with Medtronic Spinal and Biologics, where he was issued 20 U.S. patents. He earned a bachelor's degree in mechanical engineering from Christian Brothers University and an MBA from the University of Memphis. Michael will be presenting a brief overview of PEEK-OPTIMA HA Enhanced.
Great, thank you very much. Thank you everyone for joining the webinar today. I also want to thank Dr. Priebus and Dr. Bassett for taking time out of their busy schedules to be able to share their clinical experience with us. Next slide. So I'd like to begin by considering why spine surgeons choose PEEK for interbody fusion devices. And really there are two primary benefits when you ask surgeons. They state the modulus of PEEK is close to bone, which means that under anatomical loading, stress is more evenly distributed between the surface of the implant and the graft material inside the cage. And of course, according to Wolff's law, bone models and remodels in response to mechanical stresses acting on it. So higher stresses in the bone graft material should lead to bone remodeling and fusion. By contrast, if you have a high modulus of elasticity, like with titanium, it tends to stress shield the bone graft, and you get stress concentrations between the implant and the end plate, which can contribute to implant subsidence. And of course, the second benefit of the material is imaging compatibility. As you can see here, radiolucency allows you to see fusion progression through the cage where a titanium is opaque, so you can't see what's happening inside the cage. Next slide. And of course, we can analyze the effect of modulus through finite element analysis, as this study from 2012 did. The authors are able to isolate variables, and so they can look at what changing just the modulus of an implant material can do to stress distribution. So in this study, the authors found that just by changing the material modulus from titanium to PEEK, it does affect the stress distribution. So they found lower stress in titanium bone graft, as you can see in the top images, with the dark color being lower stress. And they found higher stress in the PEEK bone graft material. You can see in the lower images, higher stress should lead to bone remodeling and fusion. So the authors concluded that in these comparative results, they showed the greatest stresses on cages and end plates were found in the titanium group, but the stresses on the bone graft were found lowest in this group, so it may be inferior. Next slide. And of course, PEEK and titanium have been analyzed and published in the literature as well. Here are two papers. One is a systematic review of the literature for ACDF on the left, and the right is a meta-analysis that looked at PEEK versus titanium clinical publications. Both of these papers reported higher subsidence rates with titanium devices compared to PEEK devices. And also, they reported very high fusion rates with PEEK devices. So PEEK is obviously has a long clinical history and an effective clinical history, but it's not perfect. So PEEK is not osteoconductive, and the surgeons who decide not to use PEEK often state that bone on-growth is the #1 reason why they choose to use another material. Next slide. And we don't have to search very far to find a number of devices that are trying to optimize on bone on-growth and osteointegration. So we see 3D printed devices, porous metals, roughened coatings. And the question is, how do we evaluate these devices? How do we know if they're effective? And of course, the burden of proof on each of these is on each of these devices to deliver evidence of effectiveness. Next slide. And I think it's also important to look at the history and the literature to understand what's been tried before in order to better understand what may work in the future. So this is a animal study that was performed on trabecular metal, which is a porous metal technology. It's been available for over 10 years. And the results of this study were pretty promising. Trabecular metal implants supported bone growth into and around the implant margins better than PEEK. And the open porous structure did facilitate host bone ingrowth and bone bridging through the device. Next slide. However, when clinical data was collected, the results didn't exactly correlate with the previous animal study. So in this prospective randomized controlled study, the authors reported just a 69% fusion rate with trabecular metal, which is obviously lower than what's been reported in previous literature for other materials. So just correlating clinical results with animal results doesn't necessarily lead to the same conclusions. So I think level of evidence is important to consider when evaluating new technologies. Basic science, animal data, and in vitro cell data is fine and it is helpful, but it doesn't necessarily correlate to clinical results. Next slide. So considering the long clinical history of PEEK-OPTIMA for spinal fusion and some of the mixed data for titanium and porous metal technologies, NVIDIA sought to develop a material that could improve upon the results of PEEK without going back to metal technologies. And so the most obvious way to improve PEEK or enhance PEEK is to add hydroxyapatite to the material. So hydroxyapatite is a well-known osteoconductive material. It's been used in orthopedics. It's been used to coat pedicle screws to improve fixation. It's even been used as a graft material in spine. So it's an obvious solution to take an osteoconductive material like HA and incorporate it into the material, which is what we did to develop a new compound material called PEEK-OPTIMA HA Enhanced. The benefit is that any cage that's machined from the material will have hydroxyapatite crystals embedded in every surface of the device. So we're not just trying to address a small surface area between the implant and the end plate bone, as roughened metal technologies try to do, but we're actually addressing the entire environment. So the graft material inside the cage is exposed to hydroxyapatite. Any graft material that's packed around the cage is also exposed to hydroxyapatite. So it's really trying to address the entire environment. Next slide. And we have performed and published preclinical studies to evaluate the material. So this is a unloaded long bone model that we performed with Professor Walsh at the University of New South Wales. And this model enables us to look at the bone implant interface. Next. And in this study, we demonstrated greater than 75% direct bone contact as early as 4 weeks. And we did note differences between the PEEK-OPTIMA HA enhanced material and PEEK-OPTIMA natural as far as direct bone contact in the unloaded model. Next. Following that, we decided to perform a more complex functional model, which is a cervical fusion model, and understand if we introduce biomechanics and additional complexity, do we still see some differences between the materials? Next slide. And again, in this model, we did see differences between PEEK-OPTIMA HA enhanced and PEEK-OPTIMA natural. We saw greater new bone formation at 6 weeks, and we saw higher quality of new bone bridging at 6 and 12 weeks compared to PEEK-OPTIMA. And you can see the CT scan images of the various materials in the middle. Next slide. So in conclusion, we saw enhanced bone apposition in an unloaded model. We saw greater new bone formation and higher quality of new bone bridging in a loaded model. And now we're very happy to have Dr. Priebus here to be able to share some of his early clinical results, followed by Dr. Bassett, who's going to be sharing his early clinical results for lumbar fusion. Thank you for your attention.
Well, thank you, Michael, and thanks for allowing me to present my information here. Next slide, please. My disclosures. Next slide. So Michael went through some of this information already, but when we're looking at interbody fusion options for the cervical spine, we have autograft, allograft, different metal components that Michael went over, as well as PEEK, which is biocompatible semi-crystalline thermoplastic polymer. Next slide, please. And Michael mentioned the fact that PEEK does have similar modulus of elasticity to bone, as well as it is radiolucent. Other advantages are that it has good mechanical strength. It's very biocompatible, so the body does not react to it. It's easy to make, and we're able to house material inside the cage, different graft options there. Next slide, please. The big disadvantage of PEEK is that it does not bond to bone. It's hydrophobic, it's chemically inert, and what happens is a fibrous tissue forms between the PEEK and the bone itself, which can potentially inhibit the fusion we're looking for. Next slide. So the solution could be to incorporate an osteoconductive material inside the PEEK. And Michael did go over these studies, which did show that using HA PEEK compared to standard PEEK produces direct bone contact and a more mature fusion. So the question we have at this point is it possible that incorporating the HA into the PEEK provides bony on growth and a better fusion? So next slide, please. What I did is I wanted to take a short series of patients and see how they came out. So we have 8 consecutive patients who underwent a 2 or 3 level ACDF using the HA PEEK device. And I want to look at the clinical results, including pain and neurologic function, as well as the radiographic results, including AP lateral flexion extension radiographs at the 6-month post-op visit. Next slide. So what I did was the standard ACDF left-sided approach for the scectomy decompression, including removal of the posterior longitudinal ligament. I prepared the end plates for the spacer with a high-speed burr so that I'd have good contact between the cage and the bone, as well as some bleeding bone at the end plates. I used the HA PEEK spacer and filled it with a combination of local autograft from the vertebra, including the bone marrow aspirate, as well as VTOS BA synthetic bone graft. And then I placed an anterior plate to secure these levels. Next slide. All right, so we'll go over a few of the patients that were included in the study. So the first patient's a 49-year-old school teacher. She had a left more than right arm pain and numbness for 10 months, loss of sensation in the hand, and weakness of the left thumb. The diagnosis was a cervical radiculopathy. And as we're looking at the MRI, you can see on the right, the axial image, osteophytes and disc causing stenosis and encroachment of the nerve root on the left side there, responsible for the radiculopathy. Next slide, please. So a C5 to 7 anterior cervical discectomy fusion was performed, and the X-ray on the left is 2 weeks post-op. The flexion extension X-rays on the right show the fusion at 6 months. What we see here is bridging bone between the 5, 6, and 7 vertebra with no evidence of lucency or halos around the cage, and no movement between the spinous processes posteriorly on between extension and flexion. So this was deemed a solid fusion at both levels. Next slide. So the result was a solid fusion at 2 levels. She went back to work as a teacher in 2 weeks. The neck and arm pain resolved. She was left with some mild residual numbness of the left thumb. Next slide. So case number 2 is a 57-year-old male who works an AT&T bucket truck. He had neck pain which radiated into the left arm and hand with loss of sensation of the left thumb and index finger, and also a weak thumb. We see at, again, on the axial view, a combination of disc as well as osteophyte causing fairly severe foraminal stenosis and impingement of the exiting nerve root, and his diagnosis was a cervical radiculopathy. Next slide. A C5 to 7 ACDF was performed. Again, the X-rays on the right show the extension and flexion views, which again show bridging bone between C5 and C7 without evidence of a halo lucency or motion between the spinous processes. And again, this was considered to be a solid fusion at both disc levels. Next slide. He went back to work in the bucket truck at 8 weeks. His neck and arm pain had resolved, and he also had some mild residual numbness of the left index finger. Next slide. Case number 3 is a 43-year-old stay-at-home mom. Had neck pain which radiated into the left arm and thumb. She had severe numbness of the thumb and index finger, and the left hand was weak. She had lost coordination, and her hands could not tie her shoelaces. She had an EMG which showed no evidence of peripheral neuropathy. And look at the MRI images. We see moderate central stenosis with mild impingement of the spinal cord. Next slide. Another C5 to 7 ACDF. Again, we see the no evidence of lucency or halos around the cages, and no motion between the spinous processes between the extension and flexion of the 6-month post-op visit. Next slide. She was deemed to have a solid fusion at both levels. Her neck and arm pain resolved, and the left hand function, coordination, strength, and sensation all returned to normal. Next slide. Case number 4 is a 48-year-old female who works for the Georgia Department of Health Services. Had a 6-month history of neck and left arm pain, and had numbness and weakness in the left hand. A diagnosis of cervical radiculopathy. Again, on the axial images, we see the fairly severely stenotic foramen. Next slide. She had a C4 to 6 anterior cervical discectomy fusion. It looks on the extension and flexion films that she does have a bridging bone between C4, 5, and 6. No evidence of halos or lucency, and no motion between the spinous processes. Next slide. Her neck and arm pain and radicular symptoms had resolved. Her strength and sensation returned to normal, and she did very well. Next slide. Case number 5 is a 58-year-old female who works at home. 8-month history of pain from the neck into the right shoulder after falling off of a horse. Her numbness was progressively worsening in the hands. She was losing coordination of her hands as well as losing balance. The right hand was weak, and she had hyperreflexia with a positive Hoffman sign. Her MRI shows stenosis and core compression between C4-5, C5-6, and her diagnosis was cervical myelopathy. Next slide, please. So she was treated with a C4-6 ACDF. Again, we see a solid fusion with a bridging bone between C4, 5, and 6. No evidence of halos around the cage, bone interface, no lucencies, and no movement between the spinous processes between extension and flexion. Next slide. Clinically, her neck and right arm pain and head numbness all resolved. The coordination and balance returned to normal, and she returned to normal activities with no complaints. Next slide. Case number 6, a 45-year-old female who worked in administration. She had a 15-year history of chronic neck pain and bilateral shoulder pain. Over the past 3 months, she was having progressive arm and hand pain, numbness, loss of control in the hands, dropping objects. She also had hyperreflexia. She had a positive Hoffman sign, and she had objective motor weakness in the hands. Her diagnosis was progressive cervical myelopathy along with chronic neck pain. And we see compression of the spinal cord on the sagittal and axial views of the cervical spine. Next slide, please. So she was treated with the C5-7 ACDF using the HA-PEEK autograft. And again, we see a solid fusion between C5, 6, and 7. You see bridging bone, no lucency between the cage and the bone, and no movement between the spinous processes posteriorly. Next slide. She was back to work in 3 weeks. Her arm symptoms of myelopathy had resolved. She continued to have the chronic neck pain, but it was less severe pain than she had prior to her surgery. Next slide. Case number 7 is a 53-year-old male maintenance supervisor. He had a 3-year history of neck pain, which had radiated down the left and the right arm, but more severe on the left side. He had weakness and cramping in his triceps muscle, objective motor weakness in the triceps, and again, he did have chronic pain and was under pain management for the chronic pain. His diagnosis was, in addition to the chronic pain, an acute cervical radiculopathy, and we see on the MRI, again, fairly severe foraminal compression and impingement of the nerve root. Next slide. He was treated with a 5-7 ACDF, and again showed bridging bone between the 5, 6, and 7 vertebrae without evidence of lucency or halo, and no motion between the spinous processes between extension and flexion. Next slide. He did have improvement of the C7 radiculopathy in that his arm pain and triceps weakness had resolved. He continued to have neck pain, which was worse with driving, which was prohibited him from returning to work given his 1-hour commute. He continued to have some hand weakness and limited range of motion of his neck. Next slide. Case number 8 is a 58-year-old male carpenter. He has a history of a C4-7 laminectomy in 1997, which resulted in chronic neck pain. He was involved in a motor vehicle accident prior to him coming to see me. He had a more acute symptoms of progressive numbness and tingling and weakness, which radiated down the arms and in the hands on both sides. And being a carpenter, he was having trouble working as he could not control his hands. He did have an open canal given his prior laminectomy, but he did have severe foraminal stenosis at multiple levels, which you can see on the axial view. So his diagnosis was a multi-level cervical radiculopathy. Next slide. So he had a C4 to 7 ACDF, and again was noted to have a solid fusion at all 3 levels without evidence of halo or loosening between the cage and the bone. Could not tell posterior movement given his lack of spinous processes, but this was deemed to have a solid fusion as well. Next slide. He did return to work in 6 weeks. His arm symptoms had resolved. His hands were working well, and he was able to work and do his carpentry work. He still had intermittent neck pain, but had improvement in the function of his hands. Next slide. So those were the 8 cases involved in the study that received the HA PEEK along with anterior instrumentation. I put in 2 case studies to show a contrast using a standard PEEK cage, and so these last 2 studies involve a standard PEEK without HA. So this is a 66-year-old female who was retired. She had a 1-year history of neck and left shoulder and arm pain. She complained of neck stiffness and limited ability to turn her neck to the right. She was diagnosed with foraminal stenosis and a cervical radiculopathy. Next slide. So she underwent a C4 to 6 ACDF with the standard PEEK, autograft, and VTOS BA. And if you look at the 6-month follow-up films, we do see a lucency at the C5-6 level, especially at the superior end plate, or I guess caudal end plate of C5 and superior surface of the cage at C5-6. And if you look between flexion and extension, it does appear to have movement between the spinous processes between C5 and 6. It appears that C4-5 most likely has fused. I don't see any lucency or halos or movement at C4-5, but you do see movement as well as a lucency at the C5-6 level. So she was deemed to have a pseudoarthrosis at C5-6. Next slide. After the surgery, her neck and arm symptoms and pain had resolved, but she continued to have a limited range of motion of her neck. Next slide. All right, so the last case is a 62-year-old female administrative assistant. She reported severe neck and left arm pain. She had objective weakness in the left arm, had been dropping off objects and losing coordination. She did have hyperreflexia with a positive Hoffman sign. MRI shows multiple levels of stenosis and cord compression, was diagnosed with a myeloradiculopathy. Next slide. She underwent a C3 to 6 ACDF using a standard non-HA PEEK spacer and titanium plate using autograft and VTOS BA synthetic bone graft. At the 6-month visit, it does appear that she has a fusion at C3-4, but both C4-5 and C5-6 have a lucency around the cage and movement between the spinous processes, and she was known to have a pseudoarthrosis at both the C5-6 and C4-5 levels. And these were put in here again to show the contrast of a pseudoarthrosis compared to the fusion we were seeing in the first 8 case studies. Next slide, please. So again, she had a pseudoarthrosis at 2 levels. She did return to work in 3 weeks. Her neck and arm symptoms resolved. She did complain of an occasional neck ache, especially with bending the neck forward. Next slide. So a summary of our 8 patients, consecutive patients for the HA PEEK. As far as the clinically, the arm pain had resolved in all 8 patients. The neck pain had resolved in 5 of the 8 and improved in 7 of the 8. 1 of the 8 patients had no improvement in neck pain. As far as the neurologic function, all 8 patients had improved neurologic function with residual numbness in 3 of the 8 and residual weakness in 1 of the 8. Overall, 17 of the 17 levels appear to have fused at the 6-month follow-up visit. Next slide. So in conclusion, the HA-PEEK interbody device provides as good or better clinical and radiographic results compared to a traditional PEEK interbody fusion device. And as always, further clinical study is warranted. And that's the end of my talk. Thank you very much.
All right, so there are my disclosures. And to go over this quickly, I've done 23 years of surgery in Tuscaloosa, Alabama. Most of it is adult degenerative type procedures. Most of that involves fusion to some sort, and I specialize in lumbar failed fusions. I have experience for 23 years with interbody fusions of any sort, and we've used most any graft product there is or any type of implant at some point. Our preferred method right now has evolved into using a T-lift style banana cage with autograft. I've gone back to autograft because of the healing methods there. We currently use a cutting edge spine EVOS PEEK HA cage. This is the Optima that was discussed previously. And we use that because of the biconvex design, the strength, and the matching modulus that yields a very rapid bone fusion ingrowth. First off, my rationale for interbody fusion. I use an interbody fusion when we need a very strong, solid fusion for back pain, if back pain is a primary consideration. Most of my patients have some form of listhesis and have a nerve issue, so we use the interbody fusion here to protect that nerve. Any form of a failed fusion, we will do interbody on to get a solid fusion. And if I have a one-sided disc space collapse, and that happens to be the symptomatic side, and we need to expand the pedicle distance, that's where we're going to use interbody. We may use pedicle screws, interspinous process fixation, or facet screws, depending on how unstable it is. As I said, most of the patients we are doing for adult degenerative require some form of decompression as their primary procedure. I tend to retain the facets as much as I can, working from the medial pedicle inward. We clear the disc on the symptomatic side. That way, if we have to take down a facet totally on that side, we're usually addressing the symptoms directly. We use various curettes to get the one-sided approach. We then place a biconvex EVOS PEEK HA cage, insert it, turn it sideways, and tamp it to the front margin as far forward as we can get. That way we can maximize the space for the bone graft. And then if we use pedicle screws, we triangulate them and compress them so that the graft is under direct compression. It shows the cutting edge spine product. On the frontal view of the implant, you notice that the top is rounded and the bottom is rounded, so it matches the opposing end plates in the disc space. They have a 0-degree angle or a 6-degree lordotic angle, which is what I typically use. This is an overview of 9 patients that we did either 1 or 2 level lumbar fusions on. These go back to October 2015. They all involve the same type cage setup, and the same bone graft, which is purely iliac crest graft. We've not used any biologics in this series, so it's a fairly clean series. Post-op, we restrict anti-inflammatories and caffeine usage and any tobacco form for at least 3 months. 2 of these patients had orthofixed bone stimulators. We've looked at these patients clinically in terms of pain reduction, opiate usage, neurologic recovery, and functional recovery, which I think is most important, and then looked at any complications or reoperations that we may have in these patients. They were all assessed by AP and lateral x-rays at 6 weeks and 12 weeks, and then a CAT scan study on every patient here at 6 months post-op. The very first patient we did was October 2015. She was a work comp patient. She had a pre-existent pars defect, as you can see on the right-hand x-ray. She had a disc protrusion, approximately 6 months duration after a lifting injury. She was symptomatic for that disc protrusion, for right leg pain, with back pain. I saw her 6 months after treatment. At this point, she was taking 3 Norco per day. She had subjective weakness in the right leg. Our intervention here was a standard gill laminectomy, produced a total disc excision off the right side, which was their symptomatic side, did a PEEK-HA cage insertion with iliac crest autograft. And these are the 6-week, 12-week films. And I just want to point out that 12-week film on the lateral showing very good solid appearance. This is the CAT scan study done at 6 months. This patient's leg pain resolved fully. Her back pain improved 50% or more, and she went back to the same job without modifications. The CAT scans show complete bone graft abutment to the cage. I want to point something out here on this bottom right image. There's a white line behind the cage that you see, and I'll show this on other patients in this series. We think that white line is actually where you've got a very dense bone bonding of the graft to the cage directly, as you would expect with PEEK product, with an HA product. Second patient, a little harder to get fused. This is a smoker, 66-year-old male. He's got a one-sided leg pain with a degenerative curve into that side. He's having left-sided L3 pain. Now he has had prior FemPop stents, 2015. He's got a pacemaker. He's not a healthy guy. He still smokes. He's smoking 1 pack per day at least. Tried to get him off the cigarettes, which a lot of times these patients aren't going to quit. He did not quit his cigarettes. We ended up doing a one-sided takedown of the L3-4 disc space on the symptomatic side, elevated that side, placed our PEEK cage, and then because he's relatively stable without flexion extension instability, we've used a spinous process device here. Patient did continue smoking. At 6-month follow-up on the CAT scan, he showed partial fusion. I would not say that this is a solid fusion. There's still gaps near the cage. He had returned to farming at that point. He still had some back pain, about 25%. We had this guy follow up at 12 months, and he came in. This is recent, maybe last month he came back. He was 100% clinically fused, 100% radiographically fused. We didn't pursue another CAT scan. I didn't think there was any reason for it. And this guy's doing so well, he actually went back full-time farming and also did part-time work locally. The third patient, 68-year-old, non-smoker but diabetic patient with strictly low back pain. Now, he has a back structure that looks more like a younger person. We viewed him as a younger person with back pain. We ended up doing a discogram on him. We showed concordant pain responses at L4-5 and L5-S1. He had a long non-surgical course. He had failed, so our treatment options at this point were a 2-level fusion, which was done L4-5, L5-S1, again using the PEEK-HA T-lift cage. This time we did facet screws because we did not have instability. We used a bone stimulator on him because of his age and diabetes, and somewhat because of the slightly weaker fixation here. He's got very good, solid appearing graft fusion, 6 weeks and at 12 weeks. And on his CAT scan at 6 months, I'll refer to this lateral view. He's got very solid fusion going from the entire posterior margin all the way to the implant. It abuts the implant on both levels. He's done very well accordingly. He's had no back pain and no leg pain, and he's now exercising regularly. The fourth patient is a diabetic patient with peripheral neuropathy, having neurogenic claudication. She has a 14-millimeter subluxation. She has a reasonably significant spinal stenosis in the supine position, which you could certainly imagine would worsen when she gets up and walks. And she had your standard neurogenic claudication, especially into the right leg. We reduced her, decompressed her, and fused her, again using iliac crest graft. We used an orthofix bone stem on her for 6 weeks. These are her 6-week x-rays. The lateral view there already shows fairly full incorporation into the disc. Her 6-month CAT scans show a very solid fusion. There are no gaps in this fusion. That fusion goes from the very back side right into the implant and actually comes out the front wall of the implant. So she's grown right up against the implant. I want to show this axial view, you can see the outline of the cage and the bone graft abuts it fully. There is no seam there like you may see with pure PEEK. She's done very well. She's had full resolution of her operative symptoms. She still has peripheral neuropathy, as you would expect. The fifth patient is a younger lady, and she had an operation by a former attending of mine maybe 15 years ago, had a disc herniation. She ended up moving into my area, and I started treating her, and subsequent to that, she ended up with 2 additional discectomies for additional ruptures. I saw her on the 4th rupture, and she had some weakness in her right leg. She was having some back pain, but the main issue was a right leg weakness in the calf. We operated on her, and she had findings of a free-floating facet on the opposite side of the symptomatic side. This is one of the cases where we went opposite the symptomatic side because we already had basically a full facetectomy approach on that side. We took the disc out and did a interbody fusion with iliac crest graft. These are her early films at 6 weeks. And then the CAT scan at 6 months shows a very solid fusion. I'm going to refer to this upper right-hand image where that black arrow is. That shows that density of bone coming right up to the back of the implant. And you can see it in the bottom left image as well, where the bone against the implant is almost more dense than you would see anywhere in the disc. So we think that may be some effect of the HA in the implant itself. This patient's done very well. She has no back pain whatsoever and absolutely no restrictions. 6th patient is a 44-year-old female who, at the point that I saw her, had had 2 operations. One was a oblique cage PEEK pedicle screw fusion using a pure PEEK cage with DBM and local bone. And that resulted in a non-union. Unfortunately, she also broke a screw as a result of that non-union. These images show her after the 2nd operation where she had part of that instrumentation taken out. The bottom left image shows that she still has a part of the S1 screw on the right side, and that is abutting her right S1 nerve root. She had both low back pain and very severe right S1 root pain. The bottom right image shows the large halo cavity that you see around a PEEK oblique implant. This patient we took to the OR. What we did here was we lightly medialized the S1 nerve root off of the screw. The blue track shows where the screw entry site was. In order to get the screw reduced in profile, I used a carbide burr to shave it out instead of destroying the S1 pedicle. That would allow us then to come behind that screw and actually outside of it, starting just outside, and put our pedicle screws in. This patient did extremely well. She had full resolution of her leg pain. There are no lucencies whatsoever around this implant. That implant's bonded to the end plates. It's bonded to the graft fully on all the views. And this patient accordingly did very well. She started exercising again, and she's off all of her pain meds, which I think is fairly amazing given that she had about 2 years of pain. The 7th patient is a older patient, and this is a patient that you would typically think is going to be quite hard to use iliac crest graft on, especially 76-year-old female. She had a severe stenosis with subluxation. Our goal here was to improve her functionality. She was only able to walk 100 yards at a time before she would have to sit down, your typical neurogenic claudication. We took her to the OR. We reduced the slip. We've done a interbody fusion with iliac crest graft. Again, no biologics here whatsoever. At 6 weeks, you see excellent fusion. There's a white seam behind the implant at 6 weeks, and that seam you can see at 12 weeks. And very heavily, you see it on the top right image around that implant on the CAT scan. And again, I think that's where the bone graft is bonding directly to the HA product in the PEEK HA cage. This patient had no leg pain, full return to full activity. Very successful result. The 8th patient in this series, 8th patient here is a 46-year-old female with degenerative facet disease. Had a surprising amount of subluxation when we checked the flexion extension views in the top right corner. She has a history of fibromyalgia, but her main problem here was back pain, which we felt we could relate to the degenerative facet changes with the subluxation. She had a sacralized L5-S1. We came into this and did a single level interbody fusion, L4-5, again with the PEEK-HA cage transverse to the front and then iliac crest graft behind it. These are the 6 and 12 week views, and the CAT scan at 6 months. And again, we see this white seam around the implant. It looks like we've got bone actually growing in front of the implant. Now, we don't generally put bone in front of the implant. I think that's ossification directly onto the cage. And she did very well. She still had some fibromyalgic symptoms, but none of the severe back pain. The last patient I want to show is a failed MIS. This patient had a 2-level MIS that was staged about a year apart. The first procedure was a left-sided L3-4 MIS with a titanium implant using BMP. Second procedure was done about a year later on the opposite side in the same manner with BMP. And this patient came to us with back pain, which we felt was from a non-union, but also with severe left-sided leg pain. That leg pain appeared by CAT scan to be directly related to this bottom right image. It looks like she's got BMP overgrowth of bone in the foramen. She actually had formed more bone in the foramen than she had in the disc space, so she had a non-union and unfortunately had severe leg pain from the extra bone growth. What we did here was take down the foramen, did a wide foraminectomy on that side, and I explanted the cage, which if you've ever tried to deal with a PEEK threaded cage, they're quite difficult. You can't break them, so you're stuck to trying to carve around them and take them out. So we did that on the symptomatic side. On the opposite side, she did not heal either, but it was such a challenge getting the cage out. I didn't want to cause any nerve pain on the asymptomatic side, so we left that cage in and we just dealt with the disc by taking out what we could and placing iliac crest graft into it. At 6-month CAT scan shows full incorporation in the L3-4 disc space, even across the defect where the cage was. The cage was right here where I'm circling, and she's grown bone right across that. On this bottom left image, you can see the cage in the front. She has bone graft that extends right up to it. The bottom middle shows a profile through that cage, and you notice a bone seam all the way across it and around the side. And again, you have these dense areas where it looks like the bone has grown very thick as a result of the HA. The clinical results summary for this series: every patient that we did had at least 50% reduction in the back pain, and they all had total or near total leg pain relief. We had no neurologic sequela. We had no instrumentation failures. There were no reoperations. At 6-month CAT scan, all fusions look solid except the second patient that I showed, and we followed that guy up on a 12-month, and he showed the solid x-rays. We tend to see very rapid, very visible bone fusion in the interbody region as early as 6 weeks on these patients. And you typically see that the clinical result corresponds to that rapid growth. Some of these patients demonstrate that very dense bone growth around the implant, especially seen on the 6-month CAT scans. We think that may be an HA effect. That is yet to be proven, but it's something that we don't typically see with pure PEEK. Since October 2015, I've done 59 patients with 78 levels, all of these the same way with the T-lift biconvex cage and the autograft. We've had 1 hip dehiscence, 2 wound dehiscences. Both of these were treated with dressing changes. There were no sequelae of that. We've had no explants. We've had 1 sacral fracture beneath an L4 to S1 fusion that required pelvic fixation, but those disc spaces still healed. We've had no neurologic consequences, and no pseudoarthroses. Thank you.
All right, well, thank you, Dr. Bassett and Dr. Priestess, for that fantastic presentation. Now we're going to roll into the Q&A portion of the presentation. I want to remind everyone to please submit any questions you have into the control panel labeled Enter Question for Staff. We're going to try and get through as many questions as possible. So, Dr. Bassett, Dr. Priestess, if you could kind of let us know what influenced your decision to adopt PEEK-HA over the other available bone on-growth technologies in the market?
Brad, you want to go first?
Sure. Well, I like the general advantages of PEEK, including the radiolucency, the modular elasticity, the points I mentioned earlier. But you do tend to see sometimes that space between the PEEK and the bone, and I think it not only inhibits the bony on-growth to the cage, but also a little bit of the fusion itself. And so the idea of adding the HA to the PEEK made a lot of sense. And after a few cases in which I used the HA PEEK, I was seeing very, very quick evidence of bone fusion, which I never saw with standard PEEK. And so it was very encouraging to keep using it. And as I kept using the HA PEEK, I continued to see that kind of early onset of some bone formation, and I do feel more confident to achieve a good fusion with HA PEEK compared to a standard PEEK cage. I'm very convinced after looking at this closely that it does make a big difference.
Yeah, my rationale is similar. The modulus of elasticity of this product is right in the middle of the cancellous range, which for me is ideal. The way that my fusions are done in lumbar spine are set up for loading. We want that thing loaded. It certainly helps the graft heal better. That's what drew me to PEEK in the initial stages 15 years ago when we started using PEEK. That's part of what pushed me away from titanium. I was happy to see that that was one of the first things I checked, was to make sure that the modulus would be the same and that it wouldn't have been changed by the HA, and it's not. Then using it initially on a few cases and seeing how well these patients did. These patients tended to do clinically excellent at 6 weeks, which is hard to reproduce when you're doing lumbar fusions, and that would match with a x-ray at 6 weeks that looked beautiful. So we kept using it, and I've been very happy with it for those reasons.
Great. Thank you both so much for expanding on that. And if you could also both just kind of tell me what the most compelling benefit you've seen in your clinical experience using PEEK-HA, that would be fabulous.
Let's go first, Tim.
Okay. What I tend to see is that these patients can return to function fairly quickly. We're getting a more solid fusion earlier on, which means I have to use bone stems less. We can restrict the patient less. We can let them do more. Potentially, if you've got patients that have anti-inflammatory issues that have to take NSAIDs for rheumatoid or some other issue, they can get on those quicker. I probably still wouldn't start them before about 8 weeks, but that's a potential benefit right there. And just the surety of having a more solid fusion earlier allows me to transition that patient into an exercise program much quicker than I typically would trust.
Well, in the cervical spine, it's not quite as difficult a fusion model as in the lumbar spine, but I do see with them healing quicker, I'm very comfortable with letting them after 2 weeks kind of go back to their regular activities. I only restrict them activity-wise for 2 weeks. I don't make them wear a collar. I give them a soft collar just for comfort, but it has nothing to do with restricting motion in the neck. And I'm much more confident letting them return to their activities basically as quickly as they can. Clinically, I see less, I guess, I don't know if problem is the right word, but I see less trouble with like 6 months down the road, still having some issues with neck pain and possible pseudoarthroses with the HA PEEK. So it just helps me get let them get back to their life faster, and we seem to have less issues down the road.
Wonderful. Thanks so much for expanding on that. The next audience question is, have you noticed any difference in subsidence along end plates?
Well, this is Dr. Bassett answering. At least in the lumbar portion of this, where I've used the PEEK-HA, we've had no subsidences. We've see such a rapid fusion, and part of that is the implants up front. Most of the loading is in the central region, so the graft itself is loaded. We just don't see a lot of end plate issues with these.
I agree. I haven't either. I'm trying to think if I've had any patients since I've started using this have trouble with subsidence, but I don't think I have.
Wonderful. Thanks so much for expanding on that.
Let me comment one thing there. You certainly see subsidence with pure PEEK. You very often will see it around 6 months, and and if you ever check an MRI on these late, you'll see a large halo around these implants where there's just no bone whatsoever. So after enough time of potential movement in that area, you're going to see subsidence with it. Now, the PEEK-HA bonds so quickly, you don't tend to see that. We haven't seen it following up a year and a half now. That's how long I've been using the product.
Just of note, looking at your CAT scan images, that's extremely impressive. The amount of bone growth in the disc space and around the PEEK cage. I mean, it's just, you don't see anything close to that with using standard PEEK. That was very impressive.
Wonderful. And it looks like we have time for just about one more question. And this audience member is asking Dr. Bassett, how has PEEK-HA changed your approach to treating challenging cases?
Well, it gives me a little better flexibility in what we feel we can treat, perhaps lessening some of the impact, whereas some of the challenging cases that may go on to somewhat of a slower union, if they do heal, you'd be more likely to maybe do more anterior-posterior reconstructions. That's a very large operation. It puts the patient down so deep that we're trying to get away from those if we could. And this product allows us to do more of a standard format procedure for even challenging patients with a really good confidence that we're going to be able to get an early fusion before something goes drastically wrong, like screw breakage or migration. So I've almost gotten away from anterior-posterior procedures, not just as a result of this. Some of this is technique-driven, but certainly this product allows that confidence that we are going to get very likely a very rapid fusion, which means less instrumentation failure, which ultimately means you can be kinder to your patient with a lesser operation and get the same result.
Wonderful. Thank you so much for expanding on that. Well, it looks like that is all the time we have for today. I wanted to again thank Dr. Priebus and Dr. Bassett for their excellent presentation, and to our audience for participating with us today. Enjoy the rest of your day, and we look forward to having you join us for future webinars.